can accomplish today in lab. I'll probably do the identifying which blood vessels are where from a lab perspective in the lab. I just want to finish up the physiology part of this unit now. And so it, it's very elaborate, maybe even there's a certain degree of complexity. And I could see, and believe it or not, I can see this when you're looking at me going, what the heck is he talking about? Admit it. It's that there's a lot of controls when it comes to blood flow and things like that. So you might remember us doing this. Let me get this where it's supposed to be, and looking at these types of things. So it's fairly straightforward about this when you're looking at the relative changes that occur, and the fact that we're transferring it to the heart and the skeletal muscles, and maybe a little bit to the skin to offset heat. But other than that, there's an elaborate set of controls that go on with this particular thing. And these idea of auto-regulation, because by and large we self-regulate, and there's controls that are based on metabolism. And when it talks about myogenic, it's basically stretch. When there's too much stretch, okay, then they can respond, and blood vessels can adapt in such a way that they aren't torn by excessive amounts of flow. So there's a lot of adaptations that occur. And I say it again and again, and I said it last time you were here, we have just so many mechanisms to prevent damage. And again, that's great, but again, it's the tragedy, because when they go bad, they seem to all go bad at once. And so how many people, as you get older, and maybe you have elderly relatives like that, all of a sudden when they start to go, they're in big trouble. That kind of a thing. So and some of these are obvious. If there's not enough oxygen, if there's a lot of waste products, okay, local chemicals play a role. And I would underscore this because we're going to touch on nitric oxide again. It's a relatively new identifier. It plays a role in the development of the brain. It plays a significant role in reproductive functioning. There's a lot that we're just starting to understand. And don't confuse nitric with nitrous oxide. If you go to the dentist, sometimes they used to call it laughing gas. And so it's a kind of analgesic. And a lot of people like to do that because there's a laid people apprehension. Nitric oxide is not the same thing. And then these variety of little things that come out also from the blood vessels, they can sort of balance out each other. And that's kind of all of what it's about. And smooth muscles respond by constricting, so they can, if they're stretched, then rather than to overload with blood flow, they may constrict and limit the blood flow. So there's a lot of different things that play a role with this. And then one of the things we do see, just to summarize it, long-term autoregulation is really a beneficial thing. It's the idea as we begin to use an area more. So all of a sudden you decide I'm going to go on, on a health kick, and I'm going to do more working out. Eventually what's going to happen, you're going to get more blood flow to your muscles. For older folks like me, you end up developing increasing blood flow to the heart. So your body tends to balance it out. That's the beauty of it. And it's sort of magic in that regard. And a lot of people, I can't even tell you the magic of exercise. When we're not active, it's a problem. It really is. I mean, I was in worse shape than this when I met my second wife, and she was working in nursing home, so she had her nursing stuff on. And if you're familiar with where Cranberry is up here, there's like two outdoor malls. There's one above and one below, and there's a series of steps you can walk up. Why? She starts me step walking. This must have been, I'm like maybe 17 or 18 years ago. And I'm like huffing and puffing, and some lady walks by. Oh, that's your patient. You're helping him. I was like, oh my God. So, I mean, I up until, about 15 years ago, I didn't like to go inside gyms. Too much perspiration. Very non-active. But activity is useful. So these are just all of the things that occur where you can look at increased oxygen, increased carbon dioxide, increased acidity, increased potassium, other factors. They'll dilate, changes in sympathetic nerves, We can constrict, stretch exercises. We have a lot of controls that distribute to where we need them to be distributed. And that's just sort of a nice little summary. I don't think it's that terribly important from us from a memorizational standpoint. I'm trying to give you sort of a context to understand what goes on. And so it depends on the type of activity. Okay. At rest, the flow is relatively steady. And then you can see it, activity or exercise, blood flow increases directly proportional to that. And again, you can increase the blood flow dramatically. And they're just showing you some of the factors that are there. The interesting thing, and it's a misconception that I commented on before, the brain, okay, is constant. Okay. When there's an absence of blood flow, brain function goes down. If there's excessive blood flow, it can, I mean, it's an overload type of situation. Then you can build up intracranial pressure. You know, conceivably, you could damage the brain from that. So everything is designed for that. Again, independent of position for the most part, unless people get older, we're talking about, you know, orthostatic hypotension, how those mechanisms begin to not work nearly as effectively. So in the brain, there's a variety of these. And so it's all about the mean arterial pressure. So if it decreases, the vessels will dilate, basically to ensure that there's adequate. If it increases, the vessels will constrict so there won't be overflow. And as you can see, when it gets very, very low, so when you're talking about a mean arterial pressure of 60, I mean, that's almost, the blood flow is very limited like that. That's somebody who's clearly ill, and that's it's very vulnerable in that regard. The problem is you typically don't see that unless there's other factors. It's always been my experience that fainting sometimes had neurogenic override. Someone sees something that really bothers them, or they're inherently uh, concerned about a particular thing or an episode, overheating. I've seen that many times. Some people, they just start to feel faint. And now this is a real problem. This is really with uncontrolled high blood pressure. When you're looking, I mean, you're looking at somebody who has a blood pressure of maybe, what, 200 over 130 or one, that's dangerous. And that's the kind of thing where it's really an incipient stroke. So that's what we used to classify that. We call it, when it came into the emergency room, they used to call it malignant hypertension. And what you did was you were immediately utilizing medications to bring that down, at least to a level where the person wasn't going to stroke out. It's parlance that we would use. And then you start working on what's behind all this. Is it diet? Is there some malfunction somewhere else? You know, once you get them relatively, and the whole idea is getting them relatively stable. So the skin is interesting, and it does auto-regulate, but it really plays an important role both as a blood reservoir and for body. That's why you see with increased activity in exercise, we see increased blood flow to the skin. What that will do is it'll generate perspiration. Perspiration, as it evaporates, cools the physical plant. So it's something they need to do. It's very, very worrisome. One of the signs of dehydration, when somebody's who is perspiring stops perspiring, or tears can't form. Now you're looking at, now you start to worry about this, like dry membranes. And maybe it's a context that you're familiar with. We see it with babies when they get vomiting and diarrhea, which is relatively common, that kind of thing. So there's a lot of ways that, again, regulating temperature. So you noticed, well, you can increase that 50 times more flow to the skin to try. So we have a lot of adequate mechanisms to do that. And again, the sympathetic nervous system really is the controlling factor in that, because it's part of fight or flight, the way I look at it. Temperature rises, the hypothalamus says, okay, stimulate them, dilate the blood vessels into the capillary beds, heat, perspiration, evaporation. We're trying to dissipate the heat that's there. If it decreases, it goes into vital organs. So we don't need it so much as the skin. The concern is that we may not get enough blood flow internally. And even though you might be sacrificing a fingertip or a toe tip, at least the main physical plant is there. And that's interesting about the rosy cheeks, if you've ever wondered about those types of things. There's interesting things. It's like with people who are alcoholics, and we see they'll have bloodshot eyes, and you'll see broken blood vessels like on the nose. They're close to the surface. They're just dilated for so long that the vessels leak and do that kind of a thing. I mean, you can explain some of it with trauma. And somebody gets struck in the face. Okay, we understand that. And so there's and that's the kind of things where historically it's important. So you don't want to underreact to things, but by the same token, you don't want to overreact to things. So the lungs, relatively short pathway, relatively low pressure. The nature of veins and arteries and those capillaries is somewhat reversed. So the arteries are more like veins or venules, etc. So it's again, it's reversing the nature of the flow. There's a lot of auto and even the mechanisms. So low oxygen levels cause vasoconstriction, and high levels, okay, promote vasodilation. And that's one of the things when you get into the lung, you're going to see that. And why people with chronic respiratory disease, and it's such a tragedy, all of a sudden they'll be breathing normally and they'll have trouble breathing. Next day, and the doctor says, you're going to be on oxygen for the rest of your life. I was fine yesterday. What are you talking about? The compensatory mechanism has finally collapsed. What they do is they shunt the blood that needs oxygen in your lungs to the areas of your lungs that are healthy and not damaged. And once you run out of those, I would use another phrase, school's out. The other phrase involved the initials SOL, which I told my wife this morning I was trying to be a little less, a little more careful and use a little less bad language. Of course, I wasn't telling her the truth. So that's what I mean. It redirects at the heart. Okay. So, and a lot of things that goes on there. It's so when the ventricles are relaxed and the vessels, when the ventricles contract, the coronary vessels are squeezed. Blood doesn't get through them. Okay, but fortunately, the heart stores in myoglobin, which is kind of like the muscle version of hemoglobin, has oxygen stored. Okay, and then we restore it when the heart's at rest. Okay, that kind of a thing goes on all the time. So, control, variety of different controls. Okay, important because cardiac cells use 65%, other cells only about 25%. So, during strenuous exercise, the coronary vessels dilate. So, typically, when your blood is being delivered, and we'll see this in the next sequence of slides, when your blood is being delivered to the tissues to give up oxygen and nutrients, pick up carbon dioxide and waste products, we're only given about 25%. We get into the respiratory unit, you're going to see that. Hemoglobin only really donates about typically 1/4 of its stored oxygen. Less than most people would think. It's not like venous blood doesn't have any oxygen. It has quite a bit. It's a little bit different in the heart, which requires a greater amount of oxygen. So it's a bit different. And this is all about capillary exchanges. And it has to do with how the blood is flowing, because it's very rapid in the aorta. It's very slow in the capillaries. And then it begins to pick up speed again, because the vessels go from large, heavy flow to small, limited flow. And as they get larger, the flow increases. So capillaries have the largest area. And if you remember, we talked about that before. The more of them, that diameter increases and increases overall, and it slows down the flow that's there. And so they're looking at that. So when you get into the capillary area here, that sort of purplish color that you can see the peak there when we look at area, and you can see the trough there when we look at how rapidly it's flowing through. And it's by design. We want it to travel very slowly so we can maximally release oxygen and absorb carbon dioxide as a waste product, release nutrients and absorb other chemical waste products. And we just keep doing the whole thing over and over again. It's good. Okay. So those precapillary sphincters, I showed you a couple of lectures ago, those little bits of smooth muscle that control blood flow through certain areas. So right now we're delivering, it's like in your gastrointestinal and genitourinary system. Right now, they're getting maximum flow. The minute you start to walk to the next class, it's going to start to shunt back to the muscles. And so it's done. You don't have to make it. These are all presets that are inside. So and really it's probably designed, the beauty of using diffusion is it doesn't require energy. So we're going to utilize blood pressure to force out, and again, it's all about gradients. It's all about different levels of concentration or different levels of pressure. So when we have to do active transport, if you remember back in AP1, you probably discussed diffusion and facilitated diffusion and osmosis. This is ringing a bell. Those are all passive activities. We don't have to expend a lot of energy. But your kidneys, for instance, require a lot of blood flow and a lot of energy because you're actively transporting that stuff, the good stuff back in, and you're actively transporting the bad stuff out. I mean, it's really remarkable, and it probably hasn't changed a lot. My first wife, after she left emergency room nursing, worked for about a year in dialysis. And these units were much older than the ones we have today. And it would always amazed her when here's this person on dialysis sitting for, and the machine's doing a lot of the work, sitting for 4 5 hours 3 days a week, and they're exhausted. And that's because of all the active transport that's going on. It's sapping their energy, even though they're not necessarily physically active. So it's really, really very, very interesting how all of that went on. I mean, I'm sure things have changed dramatically. This was a, nearly 50 years ago. Oops. So diffusion is useful. Different routes. So things that are in you probably from the things that are fat soluble can cross the membrane. So oxygen and carbon dioxide are just that. They're what they call nonpolar molecules. You may or may not remember that. So they pass easily through membranes. It's a good thing. Okay. And the water soluble ones through clefts. And by and large, it's about concentration gradients or gas levels and things like that. So I think that they're very, very useful. Let me do this. I'm doing it pass backwards there. So they can either pass through these little openings, like in the kidney, the fenestrations. There are some active transport that definitely goes on when you're dealing with larger substances. And they're just showing you some illustrations. And you saw a little bit of these before. And I'm not going to go crazy going over them. So fluid goes out of those openings that I was just buzzed through at the arterial end and comes back at the venous end. Okay. And and because of that, this is where I had talked about this a little bit before. This bulk flow of fluids has a lot to do with hydrostatic pressure. That's blood pressure. Think of that as the mean arterial pressure, because that's really the way to look at it when you get to that area. And the colloid osmotic pressure, go back to the blood unit, all that albumin holding on to the fluid. So they oppose each other. When they're in balance, fluid doesn't come in and fluid doesn't go out. When they get out of balance, it's going to either force fluid out or force fluid in. And at the capillary beds at the start, it forces fluid out. And at the end, with all that fluid out, it kind of reverses itself. And now that colloid osmotic pressure, the proteins are still in the capillaries. They're pulling everything back in. Usually when I do a Godfather 3, way before your time. We used to jokingly think that you could quote a line from, this shows how old it was, from a Beatles song or one of the Godfather movies and cover everything like that. I know, long time ago. There's a very famous line in the third Godfather where he goes, "Every time I think I'm out, they pull me back in." And they used to do that on The Sopranos, again, a show that you might have had a chance to watch. Sopranos fans? See? So Silvio would do that. And Silvio's anything but that. He's been playing guitar with Springsteen since Springsteen started the E Street Band. In case you were wondering, Stevie Van Zandt. But they got some extra hair and made it black, and all of a sudden he's like that. That whole crew is New Jersey based, as well as that the Sopranos thing. It's based on a character. I told somebody this yesterday. The character was based on a guy named Jerry Katina, who was the Don in New Jersey. Okay, and I think he did like 20 years without talking. So he was perfectly. So the character was based on that. A gal I went to high school with was a year ahead of me, graduated a year before me, had a recurring role in that show. And she was part of the production and the writing team. Her name was Tony Kalem. You can IMDb her. And she's a year older than I am now. But she was like, had lead roles with like Burt Reynolds and Chuck Norris. And you're not necessarily great, but that was the most notable role for that. So she probably was in like 12 episodes. I think she wrote one. So this is what it is. Hydrostatic pressure, blood pressure. At the arterial end, it's about 35. When everything flows out, it goes down to 17. Okay. Is there some pressure in and around the capillaries? For sure. Okay. But it's relatively small. The proteins, what we call the colloid osmotic pressure, they're pulling it back in. It's pulling me back in. So they use OP for osmotic pressure. The little c is for capillaries. It's about 26. That's not going to change because the proteins basically don't go anywhere unless there's damage. That's there. So whatever pressure, whatever little pressure is in there with otherwise is relatively negligible. And so when you do the math, at the arterial end, it pushes it out. And at the venous end, it pulls it back in. Okay. So more fluid leaves the arterial end and is returned. And our very next chapter that we'll start today here in lecture is chapter 19. It's about lymphatics. So we've been spending the last couple of visits here together talking about blood vessels. There's arteries and veins, but next to the veins are these lymphatic channels, and they pull in fluids and materials that wouldn't fit in those tiny veins because they clog them. So fats, certain kinds of proteins, unfortunately invaders like bacteria and viruses go into the lymphatics. And eventually they join up. And lymphatics are really important because they're sort of where our immune system is able to typically, if there's a problem, a significant problem, address it. And we'll go, because that's sort of the next unit that we do lecture wise. And I say it all the time, so I would say I think I've said is that the immune system unit is very challenging. That's a complex area. You need to know about it because there's so much immune stuff that's going on. But here's what it kind of looks like. So you have the arterial end and the venial end, and there by the venial end, they always depicted in green. The lymphatics are not closed circuits. They have little openings that are sort of embedded in and around the capillary bed, and stuff that can't fit in the veins for whatever reason end up in the lymphatics. And the lymphatics bring it on back. So that's and it is just a good picture. Do we control flow through those beds by those precapillary sphincters? Sure. Depends on where they are. When you're exercising, one of those that's going to be closed off in the gastrointestinal or genitourinary. It's going to be wide open if you're doing skeletal muscle, whatever muscles you're using. That's kind of so it's fascinating to me how it works like that. And you show you things like this again with bulk flow, hydrostatic pressure, and so it pushes it out rather than pulling the osmotic pressure, sort of again sucking it back in. If that works for you, fine. I'm happy with that. They show you with bulk flow here. So 35 to 26, and the little bits of pressure aren't that major in and around what they call interstitial fluid. So the little bits of fluid that are sitting around the capillaries and around the cells, not a big deal. So when you run the numbers, pushing it out at the arterial end is about 10 millimeters of mercury. That's a pretty significant difference. Where do we get to respiratory? The difference when it comes to the pressure differences for carbon dioxide to eventually be expelled are relatively small. And you're going to see what's interesting, and where oxygen is relatively big to be brought in, yet they go in at the same rate. And it has a lot to do because carbon dioxide gets through membranes easier. It's more membrane compatible. I mean, you have a membrane, it's not necessarily a slam dunk that every molecule goes through at the same rate. Carbon dioxide, because of its shape, happens to get through a little bit easier. Go figure. On the venial side, remember, now the pressure, the hydrostatic pressure has gone down, but the 26 is the same. And even though there's a little bit of osmotic pressure pulling it out, it's still about 8, so it pulls it back in. You don't have to know the numbers. I just want you to know the mechanism that's going on. Okay. See, you're looking more like I'm making sense to you today. Not all of you. I still wonder. I want to put a camera back there and see what you guys are looking at on the laptops. That's what I'm saying. I know what I'd be looking at something different. I'd be looking at replay from sporting events. Why didn't we have this when I was in school? That's why my sort of, listening, my hearing memory would come. I'd be sitting there doing totally unengaged looking, and they say, Lewis, what did I just say? And I'd repeat to them verbatim. And they look at me, and I kind of give them I was that kid in front of the class, give them a hard time. Are you ever sick? No. Then I couldn't annoy you. I say, edema, too much fluid. Everybody will see this. You'll see it in your own lives. You'll see it with people you know and you love. And if you're going to work in a hospital, you'll see it all the time. Most of the time, it relates to one of two areas, the heart or the kidneys. Okay. Either the heart's not working, and it's a pump. And when the pump doesn't work, it's effectively a plumbing problem. It backs up. Just like an overflow in a plumbing system, you get the same thing that goes on here. So it all depends on where it is. On the study guide, I meant to mention this to you. I mentioned, and I forgot to do it in class. And I used to do it for the nursing students. For some reason, nursing instructors were always in love with this old term called cor pulmonale. And literally means heart, lung. Cor for heart, pulmonale for lung. And what happened when there's too much fluid in the lungs, or the lungs were clogged, it would cause a backup and cause the right heart to fail. That's what cor pulmonale is. And when the right heart fails, it can't push the blood into the lung for whatever reason. The blood backs up and it's going to start to go down, first into your abdomen, and then eventually with gravity into your legs. That's the most common way we see edema. If the kidneys aren't getting rid of enough fluid, then you begin, they're reminding me about that. With regard to, then there's too much fluid, again, it'll back up. So anything that increases capillary hydrostatic pressure, pushing fluid into the capillary, so veins, blocked blood vessels, congestive heart failure, I was talking about, high blood volume, that's the kidney portion of it. So any of those things are part of it. Inflammatory responses. You get swelling all the time with fluid. Twist an ankle, it's going to fill up with fluid. But that's different. That's more of an inflammatory process with local tissue damage. That eventually, with time and appropriate treatment, will get better. So what happens in inflammation, the chemicals that are released, whether they're from damage or infection, from trauma, from something that irritates it, from an allergic response, those chemical factors come out and they cause those little openings in the capillary, they're like this, to get wider. And so more stuff comes out. So you end up with, that's where swelling comes from. Okay. So even proteins, which will pull more fluid. And so if there's too much protein in your system, okay, then you have a problem that's holding on to the fluid too much. We don't see that. But the one we do see a lot of, and the definition of malnutrition is inadequate proteins in diet. So if I didn't tell you before, when there's a natural disaster, and whether it's the Red Cross or any charitable unit that's trying to deal with those kinds of disasters, the two things they bring in abundance, antibiotics, because there's going to be infection, because the water supply is going to be contaminated, and proteins. So they'll bring in tons of easily manageable, inexpensive proteins like beans and rice. Because beans and rice that combination makes it a complete protein, and that's really all you need. Wonderful if you do it just the right way. It's like hummus being a complete protein. Okay, hummus is made as a legume, protein-containing vegetable, so it's made from chickpeas, not complete, but they mix it with sesame seed paste, okay, called tahini, and so it's nuts and seeds are the other protein, legumes and then nuts and seeds. Yummy. I think I told you the only complete protein legume, tofu. No tofu fans? Oh, I don't know what you're missing. Oh, oh. Okay. So hyperproteinemia, and that's from malnutrition. So whether it's liver disease or again, problems in with the kidney themselves, and there's kidney damage, then whenever we see proteins in the urine, it's a big problem. That's part of it as well. So here's the quick look-see at it. So the edema, for whatever reason, okay, anything, decreased drainage of interstitial fluid, lymphatics are obstructed. There's all sorts of different ones. And there's a distinction, and you'll see it. I'll show you the next one. This is classic pitting edema. You put someone's legs are filled, typically it's the legs or the ankles filled with fluid. You put your thumb and press into it, doesn't hurt, over a bony prominence. So over an ankle, medial-malleolus or lateral malleolus, wherever it would be. Dorsum of the foot, like you're seeing here. And we grade it based on how rapidly it fills back up. And sometimes it's in there for a long time. So pitting is that capability. Now, if someone has fluid and you push on it and you don't see the pit, it doesn't mean it's less problematic. It can be more problematic. That's called lymphedema. So people with long-standing fluid edema, over time, the proteins come out in the fluid and they bond to the water, and it makes it very, very difficult to get out. Lymphedema is something we see classically with injuries more than anything else. Sometimes it's hereditarily based, sometimes it's from infections. Unfortunately, with cancer, and the one that her last name, great actress, Academy Award winning actress. It's killing me. Don't do this. I hate whenever I forget something, I go nuts. I think you figured that out already. Oh. 1990. I even know the year. Okay. Drives me crazy when I forget that. Oh, Kathy Bates. Ringing a bell, anybody? She was in like whatever, the American Horror Story. Something that'd be more your speed than mine. This is a great movie with the late James Caan, I think it's a Stephen King book where she captures her favorite author, insists that he writes a new book. So, and she wanted to catch, she's just the most offbeat character everywhere. She's very interesting, has done a lot of good movies and TV. She had breast cancer. Okay. And what they do with the breast cancer, they do a lymph node dissection, typically, because it spreads, as we'll learn in repro physiology and repro anatomy, how rapidly anything in the breast spreads to the axillary nodes. As a matter of fact, if you suspect breast cancer, you always take a sample of the lymph nodes here. And so they're clustered. And so it was so bad with an extensive that they had to do that her arm would almost daily, 6 days a week, she would go into a physical therapy unit with a sleeve to push out this lymphedema. And I'm sure that video is available someplace, because she did it to try to explain to everybody else it's not that terrible. When she was doing acting, she would wear some type of garment to prevent that from happening. But as soon as she took it off the next morning, boom. So that's the part. So I'm going back a slide. Excessive interstitial fluid. The fluid makes pitting. And all of those things, gases can't diffuse, waste products. Okay. You can, if it's more limited, compensate. But by and large, that's the distinction. It goes from pitting to non-pitting. That's a bad transition. And I've seen that with thyroid problems. I've seen that with hereditary problems. We used to see a great deal of those different kinds. So edema is an interesting word in that regard. Now, this is the part we're going to do in lab. We'll start with this today, and we're going to do a blood pressure lab with some of the technology today, and that's going to be our lab. So I'm going to go over these blood vessels for you, but not now. So I just wanted to let you know what was coming, give you a heads up. So in the remainder of the time here today, or most of it, I was going to go back, and I did send you this, didn't I? No, I didn't have it here. I did send you the study guide for the next test, right? I was looking at my notes. That's something we're doing on Monday. Watch out, kids on campus, high school kids, many. So my colleague and I, Dr. Hannah, she and I are doing this synthetic epidemic with the students. They're having it's supposed to be like a zombie apocalypse thing. So we're going to test for that type of stuff. I don't know why. Something they cooked up, literally and figuratively. This is the next chapter. Chapter 19 is where you will find this. Now that I'm thinking about it, I should look to see where it is. Okay, and it's do this. Back we go. I want to see where it is for your which week it's in. Start 3. Heart, blood vessels, not there. And I apologize that that's disorderly. Try 6, see if it ended up there. Endocrine, blood, not there. So it means it's got to be in 7. Oh, be lucky. So lymph PowerPoint, that's the one I'm working with. Okay. That's here. And then we'll be going to 20 where there's an A, B, and C. And for all of this, everybody, I have what I think is a very, very good, there's about 10 pages of this immunological document that I think is really useful. And so you're going to be able to look at it. I mean, it's a lot. Happy to do it for you. Too much time on my hands. Right? Who do you like tonight? Broncos or Kansas City? Kansas City's going to win. They better, because I have the Broncos to lose. And most importantly, the dog's getting a haircut tonight. She should. Very nice dog. Right now, he's a, pardon the expression, shaggy dog. Okay, so obviously not a group that likes dogs. Lymphatics. Think of this as the circulatory system for your immune system. Even though your immune system uses arteries and veins extensively, this is a specialized system, as I said, it's very limited anatomically. There's not a lot to it. So this portion does not take a heck of a lot of time. So it starts with lymphatic vessels, okay, sort of generically speaking, lymph nodes, which you and I forever have called swollen glands. They're really lymph nodes, and the fluid that's in them is referred to as lymph. Again, the anatomy is very, very limited. So the structural basis of the immune system, not entirely, but a great deal of it. And what they have within, particularly in the lymph nodes, are a lot of white blood cells, particularly cells that become actively engaged in dealing with things that are sort of generic immunity, our basic immunity can't handle. And so things that are part of it, names that you've heard before, the spleen. The spleen plays a role in blood circulation and in lymphatics. What it does is it sort of filters the blood, okay, and it gets rid of old red blood cells. Your liver can do that if for some reason your spleen is damaged, has to be removed. The lymphatic function, and we'll look at the spleen here. The lymphatic function is one of these way stations where potential invaders are found and reacted to. The thymus. The thymus doesn't do that part, but the thymus is critical because it's an endocrine gland. It produces hormones, generically called thymosins. And what they do is they activate the linchpin cells of your immunity, which are called T cells. They're named for the thymus. They don't start there. They're made in the bone marrow, but they mature and become, they use a fancy word they call it, competent by interacting with the thymus. Tonsils. Tonsils are embedded typically in the upper respiratory system. They're in your mouth. And what they do is because we always have large clusters of lymphatic tissue wherever we come in contact with what I call the outside world. So when we inhale or we eat, I mean, every time you inhale, you're getting viruses and bacteria. I'm sorry. You are. If anything, people found that out with COVID very, very easily. The food and drink, it doesn't matter whether the food and drink is by not definition sterile. Okay. It's treated in such a way microbiologically. When you hear about something being pasteurized, what you're doing is you're eliminating the common gastrointestinal pathogens, disease causing agents. So when you pasteurize something, you shouldn't get salmonella. You shouldn't get Vibrio. And if you didn't have micro, you'll probably learn a bit about those. That's what pasteurization does. When you do your dishes in a dishwasher at home, effectively, that cycle is pasteurizing the dishes. It comes to a temperature about 140 degrees Fahrenheit for about 30 minutes. That's what your dishwasher does. So you can take stuff out of there, and hopefully you can eliminate foodborne illness that are part of it. But other than that, there's plenty of bad stuff that's in there. And particularly, and I will say it again and again, when do you guys take micro? Next term? 2:00, section E. You know, have familiar faces. Because I have all those entry-level nursing students, and they're like, here I have somebody I can talk to. Just saying, 2:00, Monday, Wednesdays, and Fridays. I think we're upstairs in 263. And moving on, so those are areas. And plus, in your digestive tract, you have modified, they're kind of like tonsils. We'll learn about them. They go by the name on your skin. We call them MALT, mucosa, which is the lining of those entry and exit points. So whether it's anogenital, whether it's respiratory, whether it's gastrointestinal, so you have lymphatic structures there. So it's called MALT, M-A-L-T, mucosal associated lymphoid tissue, skin, salt, gut, GALT. So they have different. When you see those acronyms, and I'm not going to test you on those things, but to know that they're always there. So, and then the lymph nodes themselves that are stationed, the biggest accumulation of those upper respiratory, because that's where we come into most contact with invaders. Anogenital, we come into contact with that, and areas like surveillance area, like the underarms, particularly the inguinal areas and the axillary areas. You have a lot of lymphatics that are located over there. So it returns effectively the interstitial fluid, some of the plasma proteins, fatty substances that would clog up blood vessels, and it doesn't return them to the vessels until they're very large, usually around the superior vena cava, where it's a very, very big vein. Okay, so it's an elaborate network. It circulates. That's a fair amount. 3/4 of a gallon of fluid on a daily basis. And once it enters there, technically speaking, it's called lymph. One way, in the sense it's not a complete circuit from a starting point and back to the starting point. It starts at the capillary level and comes back to roughly to the heart by way of the superior vena cava. So it's only one way in that sense. It's from the tissues to the heart. Okay. Capillaries and then larger lymph vessels. So the capillaries, they're in the tissue cells, in between them and around the blood. We don't see them in certain areas. It's not that terribly important. Bones, teeth, and bone marrow. Okay. Even we find them in limited areas in the central nervous system, as you can see. They're like blood capillaries. They're just a lot more permeable. More stuff can get in. They have valves. So they're similar blood vessels in that way. They can take up bigger molecules and particles that are there. And so proteins, sure. Cellular debris, sure. The big problem, pathogens and cancer cells can travel there. That's why it's so important. So it's one of the things we look for. if you suspect somebody has an infection, maybe you've seen somebody who has something called blood poisoning. They'll have, so typically, let's say they had an infected finger, didn't notice it, or it was bothering them, and all of a sudden it went red line, and there's a red streak. They call it blood poisoning. It's not. That's an inflamed lymphatic vessel. So it was a misnomer when they call it, but obviously it got people's attention. I remember a kid in my 7th grade, smartest kid in the class, ended up getting his doctorate from Harvard Medical School. And I remember the blood, to this day, I can remember the blood poisoning. All of a sudden, the science teacher's flipping out. So that's part of the problem. And we look a lot at those channels and enlarge lymph nodes because sometimes cancer cells will accumulate there. So, and interestingly enough, infections are usually painful. Cancer cells initially are not. So a lot of times a painful lump someplace, typically something that's more treatable than non-painful lump. Best anecdote about that has to do with right now it would be the second most famous hockey player in Pittsburgh after Sidney Crosby, and it's Mario Lemieux. See, they're 1 and 2 on anybody's hit parade. And Mario, back in '93, he had felt a lump in his neck. It didn't hurt, so he didn't bother to say anything until one of the trainers said, "Hey, got a lump over there. Did you hurt yourself?" He goes, "Nah, it doesn't hurt. I just ignored it." Trainer made sure, went to the doctor, got biopsy, Hodgkin's disease. It's cancer. So very, very famously. And he came back that year and was able to play toward the end of the year in the playoffs as well. No recurrence. But it turned out it was familial. So there was Hodgkin's in his family. So this is kind of what they look like. Starting here, lower, you can see how they're integrated in the capillary beds, and they work their way up. And you can see along the road heading back to the heart, and what they're trying to pick up there close to the heart is the superior vena cava. That's kind of where you finally add the fluid. It's a big vessel. It's going in the heart. And eventually it'll wend its way relatively shortly to the spleen and the liver, which is where a lot of the processing will go on. So increased permeability because they have little valves, okay? And the mini valves are anchored, okay? And so when there's more extracellular fluid, when there's more stuff in there, it opens them up. And the other one, you'll see these in the gut when we get to gastrointestinal. In your small intestine, which is where most of the processing and the absorption goes on by far, nothing's even close. You're going to learn about something called villi. Villi means a finger, okay? And so in each of these villi, there's a central lymphatic capillary and a artery and a regular capillary with an arterial and a venial on either side. You have millions of those in your gut. That's how we absorb things. So the stuff that we absorb that wouldn't fit in the arteries and veins, so to speak, in the capillary bed goes into the lymphatics. So that's very specialized. So it's particularly for fat. And we have a fancy name that you're going to see the name like that that's associated with the food you're processing in your stomach. When it leaves your stomach, it's called chyme, chyme. And so for whatever reason, the lymph was named chyle, chyle. These are older terms. The term chyme you'll have to know, but the term chyle isn't that important. So in the old days, it was chyme and chyle. They had lots of that stuff, and when they bled people, and all sorts of people were full of phlegm or full of bile or full of blood, that type of that. That's sort of the in not ancient medicine, but let's say medieval is probably the wrong term. Sort of Renaissance medicine. So there you can see the mini valves, and they're anchored, and blah 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 blah, and then they feed into progressively bigger vessels that collect them. Okay. Structures are similar to veins, thinner walls, more valves, lots of crossover networking that they do. And they form different trunks, and there's different names for them. You don't have to know these. I'll show you what you have to know. The big deal, there's 2 major sites that they're collected. Okay. which one's called the thoracic duct and one is the right lymphatic duct. They have a very good illustration anatomically. The right lymphatic duct, and the term we use, whether it's veins or lymph, is drains. And you'll hear me talking about that in lab today. It drains the right side of the head and neck and the right upper arm area, and the whole right arm, actually. So head, neck, and arm all drain into this one location, very, very small comparatively, the right thoracic duct. Every other bit of lymph goes to the thoracic duct, okay? And again, cistern, if you didn't remember or know, means well. The cisterna chyli was sort of like the start of what that is. That has a lot it collected a lot of abdominal lymphatic. You'll see the illustrations that are there. So they're showing it, you can see where it is. There's lots of different trunks that are there that are part of. So this thoracic duct is really like a centrally placed lymph channel that eventually, as you can see, it deposits all the way up there into either typically the left and sometimes the right subclavian trunk that are there. So, I mean, the right lymphatic duct is basically supplying the right subclavian trunk and typically from the head, neck, and from the upper extremity. And everything else is going on the left side toward what they call the thoracic duct. And that's the illustration that kind of shows it to you. Arm, right side of the upper torso, right side head and neck. That's all, as you can see, that right lymphatic duct. Everything else, whether it's the left side of the lower extremity, the left side of the abdomen, all the rest are going in by the thoracic duct. And as you can take a look it'll all be on the left side. This is what I was talking about. Erroneously, they call it blood poisoning. There are lymph channels that were painful and red lines that were there. That really is what occasioned it. It's a low pressure system. It's very similar to the venous system in that regard. Okay. And it works the same way. Muscle activity. So that's what we do when we treat people with edema or things like that. Whether you're wearing like compression sleeves, moving along, things like that. They're used in the hospital a lot, even if people are in bed. I think I told you about that. You put compression stockings and you use devices to squeeze them, compression devices, which I had on. Actually, my wife got me one at home for a holiday gift a few years ago, which I should use more. I keep thinking the dog will chew it. Okay, so pulsations of arteries, smooth muscle walls, physical activity, etc. Okay. So, and then I mentioned this before, localized edema, anything that prevents the return. So one of the things, tumors or blockages that are there. Okay, the cancer surgery, that anecdote about Kathy Bates and what happened with her arm. And if there are some that are left and they accommodate, maybe that will improve. It depends on how severe the surgical intervention is. Swelling is the bane of existence for a surgeon. It is really, and there's no way to explain it. Why some things heal worse than others or swell more than others. By and large, for most of us, you can always tell when there's going to be a problem. Okay, because maybe it's overly traumatic. When the surgery goes smoothly, you expect the healing to go smoothly. It just doesn't always occur. It's predictable. And somebody who's good, and when I did this, when I would do, it's called informed consent, and maybe you've done it yourself, where you've had to sign a document if you're having even a minor procedure that was done, that you have to tell people that you don't know about it. Hey, sometimes things happen that we don't control. There are different types of, this is more of specifics that's in there. When we do the immune system unit, we will talk about the cellular elements, immunological system cells and other cells that help to support it. The big players in this, as you might have guessed already, are the lymphocytes. They're really the most active players. T cells means that they've come from the thymus or been interacted by the thymus. They're the more powerful representatives. And B cells, and the B stands for bone marrow, are really important too, because anytime your body has to make antibodies, B cells. So T for thymus, B typically for bone marrow, but if you use the B and think antibody, that's where they're coming from. So, and most of you, I assume, they probably still had you do the COVID updates and things like that, correct? Yes, they still require that here. I'm sure they do. And so what that immunization did was it triggered your body to produce antibodies to the COVID virus. So that was the whole purpose of that, either singular or a series of injections that were there. We talk about that in this unit as well. Fascinating unit, because now most people have a context with COVID about it. T and B cells are there. We'll talk about antigens. Antigens are markers, and the ones that we are unfamiliar with cause a lot of anything in the body. It's poorly stated there. They should say T and B cells protect against foreign antigens. We have foreign antigens and we have self antigens. Years ago, when they didn't know any better, we thought the body responded to infection or damage or cancer by antibodies. So foreign markers were called antigens, which was short for antibody generating. That's what I learned. Well, those 50 years ago when I started to learn about this stuff. So as we understood more, now we have self and non-self antigens. Your body in the first 6 months recognizes what's ever there as self. So a lot of your immunity comes from your mom, from antibodies from your mom. So it's called passive immunity. We do all this again in the immune system. That's why it's such a fascinating chapter and section. But we know now that we have foreign antigens and self antigens. And that's the distinction when we talk about the blood. It's like that. That's like, if my blood's A positive, if somebody I would somehow get B positive blood, I'd have a major transfusion reaction. It would generate ridiculous amounts of antibodies and damage. Okay. So all of those things, or things we'll get into all those things. Okay. So we're going to look more at the cells without getting to with B cells, or we'll get into plasma cells and antibodies and all that type of stuff. So they're just sort of identifying it here. There's other cells, and these are important cells in the lymphatic system. They're either in tissues, or they're in the bloodstream, or they're already on site in certain areas, like those areas I was talking about, entry points and exit points, where we most commonly get infections. And macrophages, they gobble up invaders after they've been tagged or destroyed. Dendritic cells are a really important guy in this. In the skin, you have them. In the liver, you have them. It's like they're constantly sampling anything that gets on your skin or gets into your bloodstream or you swallow in such a way that it's like they're sampling the environment. It keeps your immune system in tune. That's the good news. And the other good news is that it tries to get invaders before they're doing any significant damage. And they play, as you will see, a pivotal role in activating your immune system. So they're good guys. It doesn't mean problems can't occur with them, but they're by and large, they're good guys. They get the name dendritic. If you remember in the nervous system, dendrites had all those like pointy aspects to them, like almost star shaped. So, and they're kind of like that. They have tentacle-like projections, and they kind of like latch on to stuff. Love that. And I do a whole spiel on that about what is called the hygiene hypothesis. And that was years ago. They wanted, when children were born, they wanted to keep them away from the famous story. Can I tell you that? Henry VIII went through all these wives to have, he was not great. He didn't want to be married to Henry VIII. So they're like Alice in Wonderland, off with their head. Right? And because he was trying to have a son. His third wife gave him a son. She died shortly after childbirth, fever. Okay. The son, they would scrub the walls down with lye and chemicals. They didn't know were chemicals, but cleaning agents 3 times a day. Wouldn't let him play with other kids. Okay. So he never was exposed like we were exposed as kids. Like my mom would, would get home from school at 3 o'clock or 3:30. She'd go outside, don't come back for 2 hours. With me, it was longer. If you want to stay out, don't worry about it. Listen. And what happened was when he finally had to be with people, when he became the king, and I don't even know if he survived his minority before he actually could be the king. I don't think he was crowned. I don't think it was a coronation. He died of pneumonia. That's what we came home filled with mud and stuff, and all sorts of stuff. That's the hygiene hypothesis is where it doesn't help you. You need your body to sample all these things. I always make a big deal of that. And there's different cells. You might remember talking about reticular fibers. They're like little strainers, and we saw it in the bone marrow, and they are the system that sort of anchors all these white blood cells to be able to go through the lymph. Let me show you a picture of it here. So all of them proliferation sites for lymphocytes, where if they have an invader, they can go get busy and develop ways to fight it. So surveillance points, reticular connective tissue, because it's like a filtering apparatus. It's like you put a series of coffee filters in, and it takes a while to get through. So that's sort of the idea behind that. It's slowly, and you're going to see some interesting anatomical adaptations. Lymph nodes have multiple entry points, but limited exit points. So it's like a funnel. You have a big opening for a funnel, but it only is going to come out limitedly. And depending on how you constrict that exit point, you can make it go faster or slower. Love that. Oh, we do a lot with, wait till we get to the kidneys. We're funnel crazy. I do that because I think it's an easier way for, let me say it for you. You're not going to have to know all this stuff going forward. Okay. A lot of this I know is LTF, learn to forget. You'll learn it now and you forget it later. If it's something that's important for what you're going to do with your lives going forward, spend a little time. I understand that. I realize it's unlikely any of you are going to be teaching anatomy and physiology, but you might. So I don't want to give you less information than I give other students. I mean, I'm not doing it to the same degree as advanced students who might be trying to go to medical school, because they need a certain amount of background that's important just for them to be able to have a chance to get in there. So we understand the needs that are there. My colleague and I, we teach the MCAT class next semester. We've been doing it for the last 10 years. And it's a very, very, very difficult, very elaborate exam, and still the major criteria to get into medical school. So I understand that, but that's why I try to present it this way, because you may or may not, and you might ask, why do we have to know this? It's because I think it's A, it's part of the curriculum, and B, there might be little bits and pieces that are helpful. So pardon me for droning on. Okay, diffuse lymphoid tissue all over the place. Okay, we have lots of them. Underlying any of those mucous membranes, those openings, there's a lot of that stuff that's there. When we see the ones that are concentrated, they're called lymph nodules. They're solid. They're tightly packed. Okay, that's where the B and T cells basically do a lot of their work. You'll see patches of in the gut, those pyres, that's the way you pronounce the name, they're all over your gut. You have one big one like that. It's called your appendix, which is basically part of that. Okay. And sometimes it gets clogged and overly infected, and we have to remove them. Years ago, if somebody got a bellyache, they took out their appendix, whether it was bad or not. If they had 2 sore throats and an ear infection, they took out your tonsils. Every kid I knew growing up had their tonsils taken out because they had 2 ears. Now we know that's immunological tissue. You try to leave it in unless it's a source of problems. 2 of my kids have had their tonsils out. My daughter had 2 sets of tubes for years. Blah blah. And my middle one didn't have any of that problem. Compared, go figure. Oops. I'm almost done with this. I know it's getting long, and you can see your attention is wavering. So the primary organs where the B and T cells are either made or mature, the bone marrow and the thymus. Secondary is where they get ready to do business, so to speak. And that's where you see lymph nodes, the spleen, that acronym I gave you, MALT, mucosa associated lymphoid tissue, and all these other areas where there's clusters of nodes. And this is where you see it. So you can see tonsils, you can see it in the bone marrow, you can see the spleen, which is kind of next on the outside of your stomach, the thymus, and all of those areas. So we'll leave it there. We'll see everybody up in the lab. Like I said, I'll go over the named blood vessels that you'll need to know. And I will do an exercise with blood pressure with some of the technology, just so you can see how it works. And that'll be it. And I'll get home and take the dog to the groomer and watch the football game. I have to pick up the dog from the groomer. She will not keep the dog.